Hello and welcome everyone. I'm thrilled to have you join me today for this lecture on venous thromboembolism in pregnancy and puerperium. I'm Jie. We'll be going on this journey together to learn about VTE. So, let's get started. We will start our journey on overview of VTE to learn about the statistic in Malaysia and its pathophysiology. And then, we will make a pit stop at VTE risk assessment, where we will make a tour from pre-pregnancy, booking, admissions, and lastly, postpartum assessment before moving on to the next attraction point, thromboprophylaxis. We will then continue our journey to diagnosis of VTE and pulmonary embolism, and lastly, wrap up our trip with methods of contraceptions in patients with or at risk of VTE. It is very important for all doctors to be well versed in this topic because obstetric venous thromboembolism is a leading cause of direct maternal death in Malaysia. The annual VTE specific maternal mortality ratio in Malaysia from 2007 to 2016 has shown an increasing trend from 1.5 to 4.7 per 100,000 live birth. This is comparable to statistics from developed countries. As you can see, in a period of 10 years, a total of 155 maternal deaths were attributed to VTE. So, what is thromboembolism? Thromboembolism describes a spectrum of disorders characterized by thrombosis. We often describe them according to the location of disease occurrence. If it happens in the venous circulation, it is described as venous thromboembolism. If it happens in the lung, it is defined as pulmonary embolism. Next, we will explore why are we so concerned of VTE in pregnancy. To understand that, we need to know the concept of Virchow's triad. The Virchow's triad of hypercoagulability, venous stasis, and injury to the vessel wall provides a model for understanding many of the risk factors that lead to the formation of clots. Pregnancy itself is a prothrombin state characterized by this triad. The explanation is going to be long, so please stay with me. Firstly, there's increased hypercoagulability during pregnancy due to higher procoagulants level, coupled with a reduction of anticoagulants and fibrinolytic activities. These physiological changes were in place to counteract the tendency of excessive bleeding during delivery. Next, pregnant mothers are prone to stasis of blood flow due to compression of gravid uterus on the inferior vena cava and iliac vessels. The effect of progesterone on venous dilatation further aggravates stasis of blood flow, especially when there is immobility. Lastly, endothelial injury or vascular damage during instrumentation or caesarean section is believed to trigger thrombogenesis. The pathogenesis can be explained by systemic deposition of inflammatory complements during or after the assault, leading to vasculitis, thus making them more prone to thrombosis. However, these physiological changes are expected to return to baseline by 6 to 8 weeks postpartum. Therefore, the physiological changes in pregnancy place the antenatal mothers at a higher risk by 4 to 6-fold. The risk in the antenatal period is relatively higher in the first trimester and with advancing gestation. During postnatal period, the risk of VTE is even higher and it may increase by 20-fold if the mode of delivery is by caesarean section. Knowing all these factors, It is of utmost importance for everyone to keep in mind that all pregnant mothers are at risk for VTE, and VTE is a major cause of maternal death in Malaysia. And sadly, these deaths are actually preventable most times if all preventive and adequate treatment measures were taken accordingly. Now, let's move on to VTE risk assessment. All women should have their VTE risk assessment done during pre-pregnancy period, at booking, during admission or onset of new illnesses, and post-delivery. It is very important for everyone to document your VTE risk screening for all obstetric patients and provides thromboprophylaxis accordingly to those at risk. I believe all of you are familiar with this table. The VTE risk assessment in pregnancy and puerperium produced by KKM in 2018. It is available in the Public Health Clinic's antenatal book. The types of risk can be divided into pre-existing risk, obstetric risk, and transient risk. We will go through them one by one in the subsequent slides. For pre-existing risk factors, I would like to stress the importance of going through these factors, especially during your assessment at pre-pregnancy clinic and at booking. Pregnant mothers who has a history of thromboembolism warrant a high score of 4, followed by high-risk thrombophilia and medical comorbidities with each scoring 3. Examples of high-risk thrombophilia are antiphospholipid syndrome, antithrombin deficiency, protein C or S deficiency. Medical comorbidities include cardiac failure, active SLE, active TB, nephrotic syndrome, diabetic nephropathy, and malignancies. As for obesity, those with pre-pregnancy or booking BMI of 40 score 2, whereas BMI of 30 to 39 is given a score of 1. Other factors with risk score of 1 are active smoker who is taking more than 10 cigarettes per day, family history of VTE, and those with low-risk thrombophilia like factor V laden and prothrombin gene mutation. Therefore, please remember to be thorough in inquiring past medical, family, and social history during pre-pregnancy care and at booking. Next, let's move on to obstetric risk factors. This is relevant for VTE assessment at booking, admission, and post-delivery. At booking, if the pregnancy is assisted by in vitro fertilization, it should score 1. The rest of the risks in obstetric risk factors are more related to VTE assessment during admission or post-delivery. These risk factors include cesarean section, preeclampsia, mid-cavity rotation instrumental delivery, prolonged labor more than 24 hours, and postpartum hemorrhage, where there is a blood loss of more than 1 liter or if blood transfusion is required. Here, I would like to highlight on the scoring for cesarean section. The risk factor for cesarean section is only applicable to mothers who had just undergone surgery for the current delivery. It should not be factored in for those who had a cesarean section done in previous pregnancy. Lastly, these are the transient risk factors which should be taken into account for whenever a woman is admitted to hospital for any reason or develops any intercurrent problems throughout pregnancy and puerperial period. Patients who have just undergone surgical procedures should be given risk score of 4, except for procedures like episiotomy repair, repair of first and second degree perineal tear, and evacuation of POC. Another risk factor who is often missed is hyperemesis gravidarum. Patients with hyperemesis gravidarum and ovarian hyperstimulation syndrome often require inpatient care and they are at high risk of VTE. Hence, thromboprophylaxis is advised until the patient has sufficiently recovered from surgery or recovered from signs and symptoms of hyperemesis or OHSS. Other transient risk factors include admission beyond 3 days, immobility, dehydration, systemic infection, and long-distance travel of more than 4 hours duration. For patients who are infected with COVID-19 during pregnancy or puerperial period, their VTE risk should be reassessed upon diagnosis. Addition of risk factor of 1 for those on home quarantine, and score 3 for those who requires hospital admission. This is the VTE risk assessment flowchart in primary health care. VTE risk assessment should be completed by nurses at booking, then reconfirmed by doctors during first RME. Pregnant women who are at high risk of VTE, meaning those with history of VTE or those with risk score of 4 or more, should be referred to ONG specialists or family medicine specialists. They will need to be started on VTE prophylaxis as soon as possible. Whereas for patients with moderate risk, meaning risk score of 3, will need to be referred to FMS by 26 weeks gestation for counseling on VTE prophylaxis. This is because those with moderate risk category will need to be seen by ONG at 28 weeks gestation for VTE prophylaxis commencement. Lastly, antenatal mothers with score of 2 or less are deemed low risk. Anticoagulant is not necessary, but non-pharmacological thromboprophylaxis still need to be practiced throughout pregnancy. They should be educated and made aware of the risks, signs and symptoms of VTE, and given advice on avoidance of dehydration and immobility. That's for management during the antenatal period. Moving on to postnatal phase, patients with previous history of VTE episode should have their prophylaxis continue throughout their postpartum period for 6 weeks. Similarly, postnatal mothers who are of high VTE risk with antenatal VTE score of 4 or more should also have their prophylaxis continue for at least 3 weeks to 6 weeks, as determined by the treating obstetric specialist. Those with moderate VTE risk during antenatal period, whom were started on VTE prophylaxis at 28 weeks gestation, should have VTE prophylaxis carry on till 3 weeks postpartum. Lastly, let's look at postnatal VTE risk assessment for those who were deemed low VTE risk during antenatal period. Patients who scored 2 postnatally will need to be started on VTE prophylaxis for 10 days. This is why you would notice that all mothers who had just delivered via LSCS are given VTE prophylaxis post-delivery, as cesarean section carries a risk score of 2. Moving on to your left, mothers who scored 3 or more during postnatal period will need to be started on VTE prophylaxis and to be reassessed at day 10 to determine the risk again. If patients still at high risk, should need to receive prophylaxis for a total of 3 weeks. If it is decided that she has returned to low risk at day 10, hence no further VTE prophylaxis is needed. Lastly, mothers who scored 0 or 1 during postnatal VTE risk assessment, even though they are of low risk group, it is still the responsibility of all doctors and nurses to advise them of the risk of VTE and measures to be taken to prevent VTE like early mobilization, TD stocking, and avoidance of dehydration. This is a recap of what we have discussed in the previous flow chart. Patients with a score of 4 at booking should be started on thromboprophylaxis immediately and continue 3 to 6 weeks postpartum. Women with previous VTE or underlying thrombophilia should be managed in collaboration by a hematologist and ideally seen in the pre-pregnancy clinic. This is important because women with antithrombin 3 deficiency and antiphospholipid syndrome require higher prophylactic dose as well. For patients with a score of 3, they should be referred to obstetrician or family medicine specialist early by 26 weeks for counseling, and to be started on thromboprophylaxis at 28 weeks till 3 weeks post-delivery. For risk score of 2, thromboprophylaxis is only required at postpartum period for a duration of 10 days post-delivery. VTE risk score of 1 is considered low risk. However, lifestyle modification should not be neglected as women in pregnancy and puerperium are already at risk for VTE. Therefore, all antenatal and postnatal patients, irregardless of their VTE risk score, should be counseled on prevention and recognition of VTE. Now, let's talk about thromboprophylaxis. In simple words, it means the prevention of clots forming in veins. Generally, it can be achieved via medication or via non-pharmacological method like mechanical thromboprophylaxis and general preventive measures. The agent of choice for thromboprophylaxis is low molecular weight heparin. Alternatively, unfractionated heparin is used for this purpose as well. It is the anticoagulant of choice in patients with massive pulmonary embolism or in patients with cardiorespiratory compromise. Other agents like fondaparinux and non-vitamin K antagonist oral anticoagulant, NORACs, are not recommended due to lack of clinical evidence in pregnant women. Fondaparinux should be reserved for women intolerant of heparin compounds. Hence, its use in pregnancy should be in conjunction with a consultant hematologist with expertise in hemostasis and pregnancy. Low molecular weight heparin is a preferred choice of anticoagulant due to several factors. First of all, it is more convenient to administer low molecular weight heparin with regards to its daily dosing. It does not require frequent monitoring of platelets. It has proven safety profile in pregnancy, and it is safe in breastfeeding. Nevertheless, do pay extra attention on the dosing for patients with renal impairment, as dose adjustment is required. Furthermore, the dosage for pregnant women should be calculated based on their pre-pregnancy or booking weight. This slide shows the recommended dosage for enoxaparin, dalteparin, and tinzaparin according to body weight. Please remember that this class of drugs is contraindicated in patients with significant risk of bleeding and in patients with history of drug allergy to low molecular weight heparin. Next, let's move on to unfractionated heparin. This is the anticoagulant of choice in patients with massive pulmonary embolism or in patients with cardiorespiratory compromise. It may also be used in the peripartum period in patients who are at an increased risk of thrombosis and hemorrhage, or in cases where regional anesthetic technique may be required. The prophylactic dose for unfractionated heparin is 5,000 units 12 hourly for a patient weighing 50 to 90 kg. It is not recommended for those out of that weight range as there is lack of evidence on its efficacy and safety. Apart from that, usage of unfractionated heparin requires platelet monitoring every 2 to 3 days from day 4 to 14 or until heparin is stopped. The timing of thromboprophylaxis initiation depends on the patient's VTE risk scoring. Those with an antenatal score of 4 or more should have had it initiated as soon as possible, whereas those with an antenatal score of 3 should have it initiated after 28 weeks. Mothers requiring thromboprophylaxis in the antenatal period should be referred to a family medicine specialist or ONG specialist for counseling and further management. The initiation of thromboprophylaxis should be done in a hospital if low molecular weight heparin or unfractionated heparin is not available in the health clinics. Patients with postnatal VTE scoring of 2 or more will need thromboprophylaxis post-delivery. It can be initiated post-delivery between 4 to 6 hours following delivery or cesarean section. As for patients who are assessed as having low risk with antenatal score of 2 or less, or postnatal score of 0 to 1, they should be counseled appropriately on prevention and recognition of VTE and can continue with their routine antenatal and postnatal care unless otherwise indicated. Now let's look at what happens in the labor room. For patients on low molecular weight heparin, there is no contraindication for vaginal delivery, but vigilance for postpartum hemorrhage is recommended. They should be advised to omit their low molecular weight heparin dose if they have signs or symptoms of labor or bleeding, and to seek medical attention immediately. If regional anesthesia is required, it should be avoided until at least 12 hours from the last prophylactic dose of low molecular weight heparin. Our attention for VTE shouldn't just stop at labor room, as we know that postpartum period carries a substantial risk for VTE as well. Hence, it is important to make sure all patients have their risk reassessed immediately postpartum. This is especially important for patients who have had cesarean section, instrumental delivery, complicated or prolonged labor, associated sepsis, and other complications during labor like eclampsia and postpartum hemorrhage. If thromboprophylaxis is indicated during postpartum period, the first dose should be given as soon as possible after delivery, provided patient did not experience postpartum hemorrhage and did not receive regional analgesia. This is because patients who have just undergone procedure for regional analgesia would carry a higher risk of bleeding if anticoagulant is administered too soon. Therefore, low molecular weight heparin should not be given for 4 hours after spinal anesthesia or after removal of epidural catheter. Apart from that, epidural catheter should also not be removed within 12 hours of the most recent injection. If bleeding occurred while on low molecular weight heparin, treatment should be stopped and expert hematological advice sought. Another concern that is often raised by patients is regarding breastfeeding safety. So, it is important to inform patients that breastfeeding is not contraindicated in patients taking low molecular weight heparin. Non-pharmacological thromboprophylaxis is equally important in prevention of VTE. General measures like advice for early mobilization and avoidance of dehydration should be imparted onto all antenatal and postnatal mothers. Another modality of VTE prevention is mechanical thromboembolism, with anti-embolism stocking being the most commonly used method. The use of properly applied anti-embolism stockings, also commonly known as TED stocking, is recommended in pregnancy and puerperium, especially women who are hospitalized, women who travel long distance for more than 4 hours, or those who are considered to be at particularly high risk of VTE. It has to be fitted with appropriate size and provides graduated compression with a cuff pressure of 14 to 15 mm mercury to be effective. Other examples of mechanical thromboprophylaxis are foot impulse devices and intermittent pneumatic compression devices. Well done everyone in completing part 1. Let's take a break before moving on to part 2. See you then.